We wish Professor Kardashev a good flight and a soft landing, soft touchdown. We will look forward to further webinars with his participation. Our current president of the Eurasian EURA Association, Viktor Snezhitsky, a fellow at the National Academy of Sciences of Belarus. He will talk about, Professor Snezhitsky will talk about the tried and true, time-proven and new criteria for stratifying the risk of sudden cardiac death in patients with heart failure. Good afternoon, dear colleagues. I would like to highlight points of stratification of sudden cardiac death, SCD, risk factors, life-threatening arrhythmias in patients with chronic heart failure. The HF patients is possibly the most vulnerable category out of all of them. If we're talking about the groups of diseases that are etiological factors, factors of elevated risk, with a structural heart disease, patients with issues of heart conductivity, ejection fraction under 35%, patients with some kind of genetic predisposition, including canalopathy. Possibly the cause of death could be something else, electrolytic disturbances, stresses, a whole number of factors that can also cause fatal arrhythmias, or issues with no meaningful structural pathologies. Life-threatening arrhythmias, ventricular rhythm disturbances, although in some cases at the backdrop of supraventricular arrhythmias, or Wolff-Parkinson-White, WPW syndrome. This could be life-threatening. It's for tachyarrhythmias. For bradyarrhythmias, it could be life-threatening situations, not just systole, tachybradycardia, could be various AV blockades of second or third grade of distal type, binodal disease, as well as atrial fibrillation with cardiac arrest and clinical death. Considering this issue from the viewpoint of arrhythmia leading to sudden cardiac death, it's arrhythmias causing SCD, we know that around 60% in that paradigm is ventricular tachycardia or ventricular fibrillation. VF alone is 8%, polymorphic TDP around 13%, taux de pointe around 13%. Ventricular paroxysmal tachycardia is mostly patients with IHD, MI, history of MI, the chronic aneurysm of left ventricle. Also post-inflammation issues, post-inflammation cardiomyopathies. Hypertrophic cardiomyopathy, HCMP, is the most frequently seen in ventricular paroxysmal tachycardia. And then there is a downward frequency, canalopathies and idiopathic ventricular tachycardia. High-risk criteria are patients with early episodes of ventricular tachycardia. So it's previous cardiac arrest, paroxysms of sustained VT, paroxysms of polymorphic VT, ventricular fibrillation and systolic dysfunction. Patients with lower ejection fraction under 35, they are in the risk group, but somewhat lower. Patients of higher risk is patients with a history of MI, proximal stenosis of coronary arteries, particularly left main, sudden cardiac death is true for patients of cardiogenic syncope, valvular stenosis, particularly manifested ones, aortic stenosis, aortic valve stenosis, and patients with a history of SCD in close relatives. Of course, there are other risk factors of SCD, but these are the most frequent ones. It is very important for us to have a clear picture of their heart condition, structural heart damage, yes or no, in a specific patient. And first and foremost, given the current guidelines, we're looking at the presence of the cardiac pathology, whether it's there or not, and the reduced ejection fraction. If the ejection fraction is under 35%, we will stratify this patient into a high-risk group. And oftentimes, these patients will have the perfect indicators: primary and secondary prevention. If there were events, if there have been events, it's secondary prevention then. At the same time, there are issues, or there are questions then still. If we're looking at a 1 year or 3 year event in patients that have the ICD, only 1 to 5 of patients with CVD or cardioverter defibrillator implanted will require therapy after 1 year. The vast majority of patients with a CVD will not require therapy, or will not receive therapy after 3 years post-implantation. It is also important to note that over 70% of all cases of SCD in the general population occur in individuals with a high ejection fraction, over 35. So quite a high proportion of patients, quite a big proportion of patients is not eligible for an ICD implantation. To those whose ejection fraction is higher than 35, this is a strict criterion. Given these facts, I would like to bring your attention to the consensus document, expert consensus on risk assessment in cardiac arrhythmias. The document has been prepared, follow-up of patients using the appropriate methods of diagnostics, trying to gear the treatment to a particular population, a subpopulation, and to assess these risks, particularly life-threatening ventricular arrhythmias and SCD as an outcome. This is the data, 3 classes of recommendation in green. Green is where it's necessary and where it should be done, and the yellow is dubious, when this study should be done, and not, and red is when it's not to be done. EKG is necessary in the majority of patients with a known or presumed heart condition. When we suspect some kind of canalopathy, LQTS, Brugada syndrome, ACMP, EKG is also indicated. EKG during exercise provides diagnostic and prognostic information for syndromes such as LQTS, Brugada syndrome, ACMP, ambulatory EKG allows documenting unstable ventricular tachycardia and assessing the prognosis in patients with ICMP, HCMP, or ACMP. Also, some types of higher risks can benefit from an EKG. So this is a second grade recommendation class, yellow heart. These patients can be identified using other methods. When EKG is used with TWA, TRS, VRS, basically this gives a better risk stratification. Unfavorable events for ventricular ectopia, extrasystole over 10,000 within 24 hours, or more than 10% within a longer time period. In this case, the recommendation class is the highest. A lower class, but this criterion can also be used, is when the cardiac function assessment and screening for systems of heart failure may be considered in patients with frequent polymorphing PVCs, or PVCs with QRS the duration over 150 milliseconds, or PVCs with adhesion intervals under 450 milliseconds. Visualization methods, echo KG is important, the highest grade of recommendations, to look at particular structural heart damage and to assess the ejection fraction. MRI, cardiac MRI, is useful in determining the etiology of ventricular tachycardia and identifying any scarring, any psychiatrical or inflammatory changes in the myocardium, the hemodynamic disturbances. Most importantly, the tissues, like I said, the scarring or any fibrotic lesions can be found on MRI, or the inflammatory or post-inflammatory changes in the myocardium can also be detected by MRI. PET of the heart can be performed in some cases. This is second grade recommendation, to try to detect inflammatory or scarring in the myocardium and identifying cardiac condition. Invasive electrophysiological workup of the heart. In this consensus report, the highest class for patients with a history of MI and with syncope, and in whom the data of the previous survey did not find any link between the syncope and VT. At the same time, the syncope is suspected to be the cause of VT. Lower grade recommendation, IEPS can be performed in patients with ICM under 40% ejection fraction. So basically, it's idiopathic cardiomyopathy, ICMP, and EF under 40%, with unstable VT. No indication for ICD, the must criteria. IEPS can be considered for patients with syncope and bifascicular block with the mechanism of syncope after non-invasive examination, when the mechanism of syncope after non-invasive examination is not established. IEPS can be considered for SCD, so these are the contraindications when the QRS. So IEPS can be considered in patients with syncope or bifascicular block when the mechanism of syncope is higher. The contraindication is basically LV dysfunction, unstable VT, QRS direction over 880 milliseconds. ILR, event monitor, loop recorder, is indicated for patients with syncope and high risk criteria who have known cause of syncope, who do not have a genetically or generally accepted indication for CVD or pacemaker implantation. ILR may be considered second grade in patients with palpitations, dizziness, lightheadedness, frequent ES, unstable VT, as well as in patients with suspected AF or after AF ablation. So we should get back to the guidelines for diagnosis and management of syncope. We're looking at the risk of this syncope based on the criteria that are outlined in these guidelines, particularly ESC 2018. I will not dwell on them too much. Most likely we'll full well aware of them. Also, it is very important to assess the other side that might be useful for risk assessment for sudden cardiac death. It's a number of biomarkers that might be useful: inflammatory, fibrosis biomarkers, as well as genetic markers. Either polymorphic options of some genes or certain mutations. Genetic workup is grade 1. MRI with late enhancement to detect fibrosis or scarring can be useful when assessing arrhythmic events in patients with AF and patients with cardiomyopathy. A number of meta-analyses and RCTs has shown the benefit of MRI to improve the outcomes and to prognose the efficacy of various types of therapy. Biomarkers, this plasma NT-proBNP can be used to differentiate patients with higher or lower burden of AF. That document is revolving around other markers, particularly ST2 and XM3. Matrix metalloproteinases, MMP9, were used to assess the prognosis. But so far, the information about these has not been reflected in the guidelines. Only the plasma NT-proBNP has gathered enough data. For C-reactive protein, there's quite sufficient data to recommend plasma CRP to predict the risk of AF or atrial fibrosis development. AI and machine learning, this topic is broadly discussed these days because the data has been obtained according to which we can monitor the efficacy of AI use for both AF analysis and assessing the likelihood of systolic dysfunction in the LV detection, high sensitivity and specificity and accuracy in risk stratification in patients with IHD, high accuracy in prognosing their mortality. Mayo Clinic has developed quite a lot. A similar trial was done in Belgium for a different category of patients that were on psychotropic drugs. Also, Assis-Dale scale was used based on AI to look at polymorphic TDS or the TDP tachycardia. It's also based on the attending physician gets the information about the extension of QRS intervals, and they can use or they can take measures. For example, they can adjust the machine or they can adjust the drug therapy, sorry. If it's multi-drug therapy, that can expand or that can contribute to narrowing the QRS and prevent the ventricular tachycardia. A similar model has been created in Seattle to look at the use of ICD implantation benefit in patients with chronic heart failure and ventricular arrhythmias. It's a multi-factor model. Most criteria are clinical ones. At the same time, they're used as a certain scale. So it helps document, it helps assign points to come up with scores and come up with a prognosis. whether a patient will get benefits from an ICD or the effects from that will be minimal with respect to post-implantation SCD prevention. Once again, cardiac MRI, let me revisit that. There is a very, very interesting meta-analysis recently published last year. It was LV mid-wall fibrosis as a predictor of sudden cardiac death in non-ischemic dilated cardiomyopathy, the non-ischemic DCMP. It was shown that the use of this method and the detection or identification of the mid-wall fibrosis was negative predictive value. If there is no such finding, then the prognosis in these patients is quite favorable. And negative prognostic factor, if it's there, if the mid-wall fibrosis is there, we should implant the ICD. NNT could be, well, in this case, the intervention is 2 times more efficient. So the authors of this trial suggest using the fibrosis of the mid-wall as a prognostic factor, the LV mid-wall fibrosis as a prognostic factor, and use it as one of the criteria to recommend ICD implantation in patients with non-ischemic cardiomyopathy of the left ventricle, regardless of the LVEF. So we see a second category of patients with a higher than currently used by us, higher ejection fraction than the 35% that we were bound by. All-cause mortality is reducing, cardiovascular mortality is particularly reduced using that approach. Another meta-analysis that was done to look at the sustainable ventricular tachycardia or persistent tachycardia. Genetic workup can be beneficial. The MRI findings, echo-KG, electrophysiological studies can be useful. These combined can help run more diagnostics more successfully. Multi-factor model using this to predict, using this as predictors looks promising. Patients with IHD, with a history of MI, there was a preserved EF RCT done for them. Combined approach in risk stratification for arrhythmias, a multi-center prospective observational cohort trial was done for patients with LVEF over 40%. At least one factor was supposed to be assessed. So the patients had to have at least one non-invasive EKG risk factor, PVC, SVT, RV, elongation of QTC, increased T-wave alternation, decreased HRV, abnormal TRS. They were referred for IEPS. The primary endpoints on follow-up included the development of sustained ventricular tachycardia, VF, motivated by the activation of CVD or SCD. As a result, the two-stage algorithm helps identify the population of patients with a history of MI with ejection fraction under 40%. What's more important is that the algorithm had 100% sensitivity and 94% specificity. Positive prognostic value was 22% and negative prognostic value was 100. So not a single patient without the risk factors or with risk factors but without the induction of ventricular tachycardia, they did not have any criteria to reach the primary endpoint. So we see 2 different algorithms at least from the two trials that I've shown. In one case, it's patients with ischemic cardiomyopathy with preserved ejection fraction who do not have indications for implantation of an ICD. And the second case was non-ischemic, second trial for non-ischemic cardiomyopathy patients with this. In this case, this trial is particularly beneficial. Preserve EF data, again, it shows us statistically significant results when using this algorithm. When we see clear separation into clusters, differentiation of patients is facilitated by clustering them. Some patients have no indications, and we do not subject them to risk because we don't subject them to risk of leaving them medical aid free. Prevention of SCD is unthinkable without comprehensive lifestyle modification, risk factors modification if there are risk factors. Of course, the therapy must be looking at the original condition, the underlying condition, but given the heterogeneity, there are various approaches to treating the underlying condition. The bulk of the patients are those with IHD, ischemic heart disease. In this case, we should be looking at revascularization, myocardium revascularization indicators, and various methods related to device implantation can also be indicated. ICD or CRT. In most cases, the RFA is used. Medical therapy is often well developed. New classes of pharmaceuticals have come out. We are not separating patients, so most of them are taking ASA, beta adrenal blockers, ACE inhibitors, ARBs, the new class of pharmaceuticals, sacubitril, valsartan, statins, for example, are important in cardiomyopathy. We have to use statins. Antiarrhythmics, patients with heart failure, it's mostly amiodarone. There's not too many choices there. Pharmacotherapy for ventricular arrhythmias, we cannot use 1C class. Beta adrenal blockers are often the first line, and they're used even in the toughest cases in combination with amiodarone. Chronic heart failure recommendations, they're listed here. The list of pharmaceuticals includes 1A class. A few words about valsartan, sacubitril, if I may. Paradigm EHF was looking at biomarkers for extracellular matrix. There was a positive impact of sacubitril valsartan. SST2 and TIMP1 went down on sacubitril valsartan. Also, there was a statistically significant MMP9 reduction, metalloproteinase 9 went down. And also, most importantly, sub-analysis showed that unlike previous use of ACE inhibitors, or for example, these kind of the replacement of these pharmaceuticals for sacubitril valsartan, it gives us very good results for reducing the number of episodes of unstable VT, the number of triggers of the device. Bottom line, we had a very good result in terms of clinical status assessment for these patients. Patients with acute decompensation of heart failure deserve a separate attention. specific attention, because these are the patients prone to ventricular arrhythmias. Ventricular storm might develop. Patients with acute coronary syndrome are these. Patients with electrolytic disturbances. Other associated issues can be the cause. So this category of patients, of electric storm patients, they require specific monitoring, stringent follow-up. Oftentimes, it is these patients with QT interval elongation. In many cases, it's because of the associated COVID infection. Summarizing my presentation, these are the conclusions, these are the diagnostic methods. Mostly it's standard EKG methods. There are many of them. However, at the same time, there are imaging methods such as EKG, MRI. They also deserve, they also have a rightful spot there. These methods are not new. We have known and studied them for a long while. However, now the time is approaching when we've had certain selective groups of patients, that we need to follow up according to specific algorithms, so that the most meaningful results are studied, analyzed properly, so that we can extrapolate this data to a different subpopulation, patients with ischemic or non-ischemic cardiomyopathy. Depending on the selection of the methodologies, we can consider other approaches. Basically, it's ventricular rhythm disturbances, SCD potential, or patients with rapid progression of heart failure, and severe decompensation outcomes. Comprehensive approach is very important here. The use of OMT based on the evidence-based medicine, and the use of all the methods that are available, have been developed to date, that can be used. Today we have seen several wonderful talks by our colleagues that were looking at CRT involving the new methodology for the heart conduction system, and so on and so forth. So I believe it will take some time, some short time frame, for the experts, for the global experts in arrhythmology and cardiology, to come up with a different set of guidelines for these conditions. Thank you very much for your attention. Any questions? Viktor, thank you very much for the talk. It's a powerful presentation. I even made several snapshots without your permission, but with your permission, I would like to use them later on. Most recent findings, most recent results. Oftentimes, cardiologists ask us, they love amiodarone, cardiodarone, and they always ask, does amiodarone or cardiodarone work to prevent SCD, especially if we're looking at secondary primary prevention? Your opinion, to go for it or not? The trials are not showing that it's too helpful in preventing SCD. What about your opinion? Yuri, there are various trials, there are meta-analyses. Some of them have said that it does not affect mortality. However, well, I have failed to cite that meta-analysis in my presentation, but I have it right here, that yes, there is evidence of arrhythmic-induced mortality. Most likely it depends on the cohort of the patients. For example, if it's patients with ischemic cardiomyopathy, and most likely we will get a longer benefit. However, I will warn against the long-term amiodarone prescription, because what we want is to prevent mortality in 1, 3, or 5 year time frame. amiodarone is not prescribed often, for a long time, at least in high doses. If the situation requires in patients with ICD and with frequent triggering of the device, yeah, in that case, we're supposed to prescribe it for a long time. However, if the patients are free of ICD, there's no implanted device, the risk might be quite low. Even if the ejection fraction is more than 40%, a patient with cardiomyopathy, with chronic heart failure, well, we're not using amiodarone for a long time because we don't want toxicity to kick in. We don't want those adverse events. Unfortunately, we don't have anything aside from amiodarone to try to combat the extrasystole, the unstable VT. Sotalol is much worse in this respect, especially for the QT interval, its length. Sotalol has 10 times higher frequency of development of these adverse things. If it's hypokalemia or creatinine level elevated, sotalol brings higher complications. We're not reducing risk, we're increasing risk because of that. Other groups are not desired for the patient, other groups of drugs. Okay, great. Thank you for the wonderful talk. Let's get a flashback of the 8th webinar. Thank you. And then we will announce the 8th talk of the day.